we're group 2, I think. We are Amber, Haley, Thomas, David. So we did an article over effects of a functional therapy program on motor abilities of children with cerebral palsy. So the purpose of this was to determine whether the motor abilities of children with spastic cerebral palsy, or pretty much just any kid that has a really severe form of cerebral palsy, who are receiving functional physical therapy or physical therapy with an emphasis on practicing functional activities, we'll talk more about that later, improved more than the motor abilities of children in a reference group, or basically just they took 2 groups of people and they did one physical therapy where they worked really like on functional activities, and then one of them where they just did the very like minimum normalization of the quality of movement. So we'll talk more about it later on. And they hypothesized that children in the functional group would improve more over time than children in just the, not really control group, but the group that didn't have as much. So cerebral palsy is just a description. It's not a specific diagnosis, and it covers a number of neurological conditions. Every person that has cerebral palsy is different. I mean, I've worked with children in Bo Shear's school here in Tyler, and there's plenty of children that have cerebral palsy. You can tell that they do, but everybody is different. So it's just, it's not a specific diagnosis because not everyone is the same. And it's just an umbrella term covering a group of non-progressive, so nothing that gets worse, but it does change sometimes. So that's why physical therapy is so important for people or for children with cerebral palsy, because if they can, get their functional activities normal, then maybe it can, as their symptoms change, maybe they can go back and remember what they learned. So there's no evidence existing that brain damage can be reversed. So therefore, treatment for cerebral palsy just focuses on how best to help that person maximize his or her potential. So to teach that person how to deal with it in their daily lives. So children usually receive a physical therapist to facilitate motor development, which enhances independence of motor skills, self-care, so how to use the restroom, how to eat, all those things, how to play, and then leisure activities. So there's been many treatments that have been developed. A lot of these, are just like those are just bullets, so we're not going to go over it. But the 2 main principles that we recognized are the emphasis on normalization of the quality of movement. So just the physical therapist going in there saying, lift your arm, 5 times, or let's, roll your wheelchair this many times, or, just whatever. Everybody's different. And then there's the other one that's emphasis on functional activities. So the first approach is going to focus on eliciting and establishing normal patterns of movement through controlled sensory and motor experiences. And these experiences are intended to inhibit abnormal movements and to facilitate postural adjustments to promote functional movement. And this approach is, it has a lot of criticism towards it because there's questions regarding whether facilitated automatic movement improves voluntary active movement. So, that the physical therapist can get that person to learn how to do movement on their own, but is it going to be, that's voluntary. But later on, if something were to be like thrown at them, are they going to be able to catch it? Because that's voluntary. And then postural control, functional activities, and active participation of the child are now emphasized. So this will be the functional approach. And a strong emphasis continues to be placed on handling techniques to influence muscle function and patterns of posture and to organize movements. So to get it in their brain to where they can, connect their neurological with their functional. And this approach also emphasizes the role of environment in the task. So, we learned about that in this class here, that it's environment task. And whether that child is going to be able to, it's like more of an active view of learning rather than passive. So functional physical therapy emphasizes the learning of motor abilities that are meaningful in the child's environment. So like I said, if the child's sitting there, they want to get the child to be able to catch a ball, which is voluntary, instead of just doing involuntary movements like lift your arm 5 times because they're used to doing that. So environment elicits action. So the individual actively explores it to detect info that supports actions necessary to achieve the goal. And then children practice these motor abilities in functional situations. So that's where the functional part comes in, with the child having an active role in finding solutions for motor programs rather than the physical therapist handling the situation, which would be the other approach.
I've got the methods. In the methods, there were the participants, the procedures, the interventions, the instruments, and the data analysis. The children, in order to be inducted into this study, they had to meet the following criteria. You had to either have having cerebral palsy diagnosed by a pediatrician or a rehabilitation specialist, or they had to be between the ages of 2 and 7. They couldn't be attending a school for special education, and they couldn't be treated at a rehabilitation center. There were 55 children that were analyzed. The age, the median of it was 57. Then there were 32 of the children had hemiplegia, which was just one side of the body. There was 11 of the children that had diplegia, which is a pair of the same extremities, and then 12 with the quadriplegia, which was all of the extremities. They were separated into 6 blocks, and each of those 6 blocks, there was 6 blocks in each group. And they were determined out of age and whatever type of cerebral palsy that they had, which was listed. There's group 1, which was the functional physical therapy group. There were 28 children, and they received this type of physical therapy that was different amongst group 2, which was the reference group. As I said earlier, the reference group was just the normal, standardized protocol for treating someone with cerebral palsy, and group 1 there was they had a special kind of protocol, which will be explained later. The procedures. Once the children were assigned to the groups, they were pre-tested by a physical therapist. The functional physical therapy group received a special training program that focused on the systematic application of functional therapy. The reference group received normal treatment with a different type of protocol. And then after 6 months, after the pre-test of the measurements, the first follow-up assessment was taking place. And these assessments are taking place by the same people. They're evaluated by the same people, and they're licensed. They're trained about it, but also they don't know they don't know the protocol for it, just to keep bias. They didn't want to, affect any of the results. 19 of the 27 children in group 2 were treated according to the neurophysiological treatment method, the NDT, while the remaining were not treated according to a specific method. And this was because once they were placed in a group, it kind of depended on which type of cerebral palsy that they had in order to do the neurophysiological treatment. The intervention for group 1 was not standardized because each child had a different problem in performing functional skills, and the physical and the social environments of the children were never the same. The instruments, they used the GMFM as one of them, the gross motor function measure. It's just used to evaluate an instrument designed to detect change in gross motor function of children with cerebral palsy. It tested the 5 dimensions. It's kind of like, as you're growing up, the lying and the rolling, the sitting, the crawling and the kneeling, the standing and the walking. And for each assessment, the GMFM was administered to the child by the same tester in the same standardized therapy room. And now the PEDI, the Pediatric Evaluation of Disability Inventory. It was just a judgment-based standardized instrument using parent report through a structured interview. So kind of like it says, the parent was interviewed, and it was just based off of an evaluator who knew the information, not the actual what method they were in, what treatment they were getting, but they were trained to know the correct protocol. It measures both the capability and the performance of the functional activities in daily life situations in the 3 domains such as in self-care, the mobility, and the social function. Capability was measured by the identification of functional skills that child had mastered. And the performance of daily functional activities is measured by the level of the caregiver assistance to the child needs to accomplish major functional activities and by the number of modifications. So the performance of daily functional activities is measured by basically that was what the parent would do in the interview. It would just kind of give an example of what they could do and couldn't do on their own. The data analysis, the hypothesis with respect to the outcome variables were analyzed using just one-tail repeated measures analysis of variance. The probability of the type 1 error alpha was determined as a 0.05.
I had the results portion, and what they found is that both groups improved on both standards, but there was not a difference in the gross motor function in the walking, the standing, and running, which were like the last 2. But they did find a difference in the PEDI, which was the they found that there was a difference in the Pediatric Evaluation of Disability Inventory, which is what he said is based on the parents or the caregiver at the time. So they found that the scores are up here, and what it is it's based on a 100 scale, and as you can see that both groups improved, and this is for the gross motor. So as they improve, it goes from the pre-test to the follow-up, the second follow-up, the third follow-up, which is consecutively done over, I think it was like
6 months.
a 6-month period, so they probably did it in like increments of 2 months. What they found is that there's a huge improvement going on all the way through. And so they found that since they improved in all domains for the time effect, which was, they had 3 major effects which they considered was the time, the group, and the group in time combined. And for the gross motor function, there was no difference due to the group in time or the group by itself. The groups did not differ with respect to degrees of improvement. And they improved only in the 5th domain, which was the standing, and then the walking, running, the more large gross motor function movements. So what does it actually mean? There was an improvement for both functional therapy and the reference group, whose focus the principle of normalization and quality. When using the GMFM, there was no significant difference in improvement. So they both had the same amount of improvements, essentially, when using that type of measurement, which was based on the gross motor function. This is for the petty, and as you can see, it's still on a 100 scale, and the improvements are not as large, but they're still a gradual increase. And when you look at, they have it broken into self-care and mobility, and for the reference group, there was an increase, but it's not as large as what the functional therapy saw. So what they said is that there was an effect found for mobility in the functional skill scale. The means of the score of the children in functional physical therapy group were higher than the mean scores of the children in the reference group. So what does it mean? The finding indicates that one group improved more than the other in both capability and performance of self-care and mobility activities. The groups indicate that the children in the functional physical therapy group improved more than children in the reference group. When considering age, there's an effect of age, because there's such a broad range of ages 2 to 7. They found that the ages did have an effect, that the younger children improved better than the older children. So when they were at a younger age, if you start the physical therapy earlier, they tended to improve better and faster. There was no age group and time considerations together. When they considered all 3, there wasn't a difference. Okay, for the problem definition in the therapy globes, this is for like the actual therapist, what they noted when they had to do when they're explaining to the parents what needs to be done, or explaining different things like that. So during the pretest, the groups did not differ at all. The therapist came at it the same way with both the reference group and the functional therapy group. For the functional goals, they had, for reference group, the change was pretest of 17% to the first follow-up to 14%. So there was a decrease in goals defined for them. And then for the functional group, there was a huge increase from 18% to 57%. And then for the problem definition, it did not change at all for the reference group, but for the functional group, it increased to 40% on the first follow-up and then decreased from there after that. Now for the frequency and duration, the difference between the groups was significant because when they first began, they both started with about the same amount. And so for the reference group, it was 3.8 days per month, which increased to 4.3 days per month on the last follow-up, which means that they had to start seeing it more. For the functional group, it decreased to 2.4 days per month from 3.4. And the duration stayed the same with 45 minutes of therapy and then a 15-minute consultation. There was no change for the reference group in the actual duration, but for the functional group, there was an increase on the first follow-up, which continued to decrease after that. And they found that there was more consultation time with the parents or the caregiver for the functional group, but it decreased after the first follow-up.
All right, I have the discussion and conclusions. So basically, like you said, there was no differences found between the 2 groups, but when the functional skills and daily situations, children were in the functional physical therapy group, improved more than those in the reference group. So like they've said a lot, GMFM is the gross motor function measure, and PEDI is the Pediatric Evaluation and Disability Inventory. And basically GMFM, gross motor movements, and PEDI is like fine motor movements and like learning how to brush your teeth or take a shirt off or on or whatever. And then when interpreting the results of this, it's important to realize that both scores for this were high, and so in particular the scores were high for both domains of the GMFM and the mobility domain and the caregiver assistance scale of the PEDI. And in the last, like he said, it's scored to 100, and so in the last follow-up session, the mean scores for some children were near 90, so it was really good scores. So like in general, we conclude that the application of a functional physical therapy program has positive effects on both the child's capability as well as the performance or independence of daily functional motor skills. Some of the advantages to the functional approach are more purposeful and like functional, and it's clear for like parents and students and everything, and the improvements were more apparent. And then some of the disadvantages were time constraints, and like if they got frustrated because some of the stuff was kind of difficult for them, it could kind of get hectic. And so one thing to note is that all the students, the study can't be generalized to all kids with cerebral palsy because every child's different, they have different circumstances. And then the children that were participating in the study were all, they had mild forms of cerebral palsy. And then also the therapists and parents that participated in this were volunteers, so they were actually like motivated. And so a couple things, future studies should be performed to determine like which children and for which parents this approach would be useful. And it'd be interesting for the study of application to see like how the functional approach like works for different people and like different like professionals and stuff. So we chose this topic because we're all trying to be either like physical or occupational therapists. So learning about like a physical or like a method for kids with cerebral palsy is like interesting for us and may like help us later on in the future.
So just so we can keep this rolling real quick with this. So it was interesting that the control, if you will, was a reference group where they still received some form of treatment, but it was called normalized treatment, standard treatment. So, why can't there be no treatment? Why can't there be a true control of that?
Because there would be no improvement.
Yeah, there would be no improvements at all.
You wouldn't have anything to compare with.
Well, yeah, and it's unethical.
Well, that's
But, so the subjects were hemi, di, and quadriplegia, or they experienced CP that affected,
Motor function.
yeah. What if they just did, quadriplegics, or even not quadriplegics, but, like it affected only those areas. The CP affected only those areas.
Well, that's also why they were separated in blocks. There were 6 blocks in each group. So each one, they got their specific type of therapy, but also it's a methods that, in the functional physical therapy group, there were some tests that weren't standardized because there were so many differences between each of the blocks.
It might have been better if they would have done just like one, like, just quadriplegic.
It's hard to also diagnose because sometimes cerebral palsy doesn't set in until a little bit later. So, they could show signs of just hemi and then end up being, die. So, well, die. Not die, but.
Yeah, I got you. Well, good job, guys. Okay, what was the parent report? What was that?
That was
the PEDI. It's just like the parent or the caregiver, depending on who they have, like how severe their cerebral palsy is. That was the PEDI. They use that for circumstances. So they're like, what can your child do and not do right now? What are some of the goals that we want to set for them to be able to, do you want them to be able to brush their teeth or take care of themselves? And essentially that's what they're basing that score off of.
It was a tough questionnaire.
How reliable is that?
Well, that's why they had the trained evaluators there was there was certain things that were already set. So like whatever the parents answered, it would follow under a certain category, and then they would differentiate like that. So to be honest, it probably couldn't be just completely accurate,
Yeah.
but I mean, experiments show that it works.
Thank you, David.